people, multiple things, and you have to ask your patient what they're looking for and what they're expecting for the refractive surgery. So all my colleagues have gone into this. I'm not going to go into what is the modern day refractive surgery, but we have to understand our machine, our techniques very well without comparing it with one technology to another. And this is what ELITA SiLK has to offer us. And what I love the most about this machine is the spot spacing. And that's what I'm going to focus on, the spots and the shape. The spots are next to each other. They are placed 1 micron next to each other, and they are as small as 1 microns. So traditionally, when it comes to refractive surgery, you identify the anterior and posterior plane. That's what we do. And then you go ahead and dissect the anterior and the posterior plane, as we will, like a wiper movement. You dissect the anterior part and then the posterior part. You can see how easy it is in SiLK surgery to dissect it and remove the lenticule. And that is what we traditionally do. Now, what SiLK has is, it's the minimal spot separation. The spots are next to each other. So technically, there are no tissue bridges, and that's what gives an advantage of a smooth dissection. And that because there are no tissue bridges, because you don't have to dissect, it's minimal activation of keratocytes, and that's why you get a good optimal visual outcome in our patients. Now, because the spots are next to each other and because there are no tissue bridges, I will come to my disclaimer at the end of the slides, but what we have been aiming to do is we try to dissect it as minimal as possible, and we just identify the anterior and the posterior plane. You have to be little 45 degrees up and 45 degrees down to identify the planes correctly, and we just try to swipe it once. You can see how easy it's become, I was trying to do a wiper movement quite a lot, and here now I'm just doing one swipe technique in the anterior plane, one swipe technique in the posterior plane, because the spots are next to each other. You need minimal dissection, and you remove the lenticule. So minimal your dissection, minimal activation of those myofibroblasts, and that's when you give good quality of vision on day one, and that's possible because of the spots next to each other. And this is what I was trying to say, that minimal manipulation, a wow vision on day one. Sometimes if the manipulation is more, that's when you not so wow vision. So you just have to refine on your energies and get to the spot where we are. And with further refination, and because of the benefits of the low energy and the spots separation 1 micron, we are trying to attempt something which is the peel or the one swipe technique, where we are just trying to grasp the lenticule, and then we are trying to dissect it and swipe completely in both the directions in the planes, and kind of a perpendicular movement like a rhexis, and that's what we aim to do, and we call it the pressure exerted extraction of lenticule. You identify the anterior and posterior plane, you grasp the lenticule, and just do like a rhexis. You can see how easy it is. You go on one side, finish 0 to 180, 90 degree, and go to the other side and remove it. That's when what you can do with 1 micron spacing and spots next to each other. Now, as Rahil mentioned, if you further optimize the energies, this is what you land up in. Now, I just, separate the anterior and the posterior plane. I grasp the lenticule, and I just push. I don't even do a rhexis. I just push and pull. It's just like your femtosecond rhexis. It's like your catalyst. Why do you do your femtosecond rhexis? When you have a femtosecond rhexis, you just go inside, take a forceps, just grab the rhexis in the center and bring it out. That's what something you can do with one spot, 1 microns difference, and just push, pull like a femtosecond rhexis, and that's when what you have to achieve when you have it. And when you have minimal manipulation, day one, the cornea is clear. You can see the retroillumination picture. The surface interface is smooth. There is the objective scatter index is 0.8, which is quite good. And there is minimal activation of keratocyte. And this is how you see the granularity. It's very smooth. That's what gives your patient day one outcomes. And of course, Dr. Shetty has mentioned this. I'm not going to go into this. Now, what are the other benefits or other advantages of ELITA SiLK? Now, when you have a lot of patients who have high astigmatism, -4, -4.5, or even higher, you always aim that, let's do a topo-guided LASIK, or let's do a wavefront-guided LASIK, because this patient has higher cylindrical power. I want to take care of the aberrations. Now, in SiLK, the advantage here is that we have a cyclotorsional movement control. If you have marked your 0 and 180 degree, you can actually manually cyclorotate the surgery or the laser pattern. And I'll just fast forward the video a little bit. You can see I can manually center it in the pupil in the Purkinje images, and then I will just cyclorotate it by 10 to 12 degrees so that it's in the right plane, and that's how the cylindrical power error corrections are much better. It reduces the risk of residual astigmatism of these patients. And the patient I saw, the pre-op was minus 4.5. Post-operatively, this is what you can see the day 1 ARR was. Then the patient was reading uniocularly 2010 and 2016 and binocularly 2010 on day 1. We have taken this study further, and we have 90 eyes now operated with 2 or 2.5 diopter of astigmatism and more. And we compared it with LASIK surgeries, and then you can see that at 1 month post-operatively, 100% patients were achieving 20/20 or better. The coefficient of determination, which is the R-square, was 0.995, which is also superior. It showed no change in, basically it was 20/20, but 41% of the patients showed gain in line, and also the residual astigmatism was much better. So because of the cyclotorsion control, you can actually go ahead and attempt doing a higher cylindrical correction in this patient with much superior outcomes on 1 month or better. Now, everybody's been talking about the biconvex shaped lenticle, and Rahil did show this video, but we wanted to prove the benefits of the biconvex shaped lenticle. So we did some ray tracing work and constructed what the biconvex shaped lenticle is doing. And one of the advantage what we saw was in low myopes. The low myopia correction, which is 2.5 diopters or lesser, was much better here. 59% patients at 2016 on 1 month. And you can see 56% of the patients gained 1 line or better in lower myopes, which you'll probably not attempt with a lenticle surgery. But here, because of the biconvex shaped lenticle, grasping or dissecting the lenticle is much better, and that's how the outcomes are good. Rushad has already explained the aberration, so I'll not go into details of it, but our results have been similar, and this is work which is recently published along with Hong, who was one of the masterminds behind the technologies. But to talk about the depth of focus, how the biconvex shaped lenticle helps, what we did was we compared the near, the intermediate, and the distance vision with an E-metrope. E-metrope is something which are the patients who never had any refractive error. And what we can see is the post-surgery outcomes in terms of depth of focus or depth of field of a post-SiLK eye was as good as in healthy individual. So that means post-surgery, you are not losing any depth of focus, but the quality and quantity of vision of these patients is much better. Now, everybody, including myself, we don't want to age, but as we age, our eyes also age. And then comes the question of presbyopia and refractive surgery. So again, this is not a presbyopic refractive error correction, but because of the biconvex shape of the lenticle, and as Rushad mentioned, the curvatures are being maintained quite well, the post-SiLK presbyopias, they needed less accommodation to see intermediate and near compared to that of a patient who underwent LASIK. So because of the shape of the lenticle, the depth of field, the depth of focus, and the accommodation maintained was also quite better in these patients compared to other. There's always been a debate in comparison to LASIK whether there is reduction in biomechanics or the corneal strength post-surgery or not. So we did compare this results of SiLK, which was done at 110 microns, along with LASIK and SMILE, which was done in 100 and 150 microns. What we see that there is a lesser drop in biomechanics in SiLK compared to that of LASIK and SMILE being performed as well. So it is actually the biconvex shaped lenticle is helping us maintain the biomechanics and the strength of this as well, and that is because when you have a biconvex shaped lenticle, the collapse of the collagen fibers are much lesser, and the disruption of the collagen fiber is much lesser here compared to that of a LASIK patient or any other patient. So this is what you see, that the collapse is much lesser here. So to conclude, yes, it does have a low energy laser. The spot size and distance is also giving us a benefit to have a minimal dissection or no dissection at all. It is having minimal collagen disturbance or minimal Bowman's disruption, and that's why with laser optimization, we are able to get post-op wow vision for these patients. So the entire work and technique, what I presented here, is because of the support and the wonderful technology J&J has developed, but the data, outcomes, and the techniques are our own clinical experience and judgment. Of course, we do want to share our experience and encourage fellow colleagues to explore and do the similar techniques and give wow outcomes to your patients as well. So thank you.
Okay, thanks for the Pooja. I have only one question. In terms of the peeling techniques, so it doesn't matter if you go inside the anterior part or posterior part, right?
Mm-hmm.
So which you feel more comfortable to enter the posterior layer first or the anterior?
So I think the way the shape of the lenticule is, if your instrumentation for entering or identifying the plane is not proper, like 45 degrees up or down, you kind of go into the posterior plane first. So you have to be mindful when you are identifying the plane that you go 45 degrees up, so you are in the anterior plane, and you go 45 degrees down, so you are in the posterior plane. That ways you find out that the plane identification and dissection is appropriate, and you don't go into posterior first.
So his question was, you prefer to go into the interior plane first for your peel technique?
Peel technique, you have to grasp both the planes. So
Yeah,
you
I
dissect
understand.
the
So
anterior first, then the posterior,
anterior
and then
first,
grasp.
that's what he was
Yeah,
asking.
yeah,
Anterior first.
yeah.
Thank you.
Sorry. Yeah.